Hello, everyone. Thank you for coming. Welcome to NAUTO's 39th Annual Conference. We will be starting in about 1 minute. Before we begin, we want to cover a few housekeeping items. On your attendee screen, you can enter comments or questions in the chat. We hope you will take advantage of the opportunity to engage with our speakers and other attendees. This session is being recorded. We recognize and thank the California Healthcare Foundation for being our Petabyte sponsor. Information about all conference sponsors is available in the sponsor area of the platform. Please take a few minutes to visit each sponsor's booth where you can find information about them and find game tokens. Game tokens are keywords or phrases used in the token hunt game for a chance to win a prize in the daily drawings. Now, let me turn the stage over to Charles Hawley, NAUTO's Director of Projects. Charles, the stage is yours.
Thank you, Erica, and welcome everyone to this session titled Proud Moments and/or Difficult Challenges. I'm excited to introduce and bring to the stage Betty Harney, who will be your moderator. Betty is with CHIA in Massachusetts, the Center for Health Information and Analysis. Did I have that right, Betty?
That is correct. Thanks, Charles. Hi there. I'm the Director of Data Enhancements at CHIA here in Massachusetts, and I'd like to thank Helen Fig and Norm and Charles for their help in preparing for this session, which, as Charles said, is called Proud Moments and/or Difficult Challenges. This is an opportunity for us to celebrate some of the achievements of all of you across the country in the last year, and also to recognize some of the challenges related to those achievements that were overcome and/or remain at this point. So without further ado, I'd like to introduce the first presentation by Lauren Seno. Now, Lauren is the Director of Healthcare Strategy at the National Opinion Research Center with the University of Chicago. And her proud moment is the performance of a survey on the challenges and the role of emerging technologies in the health information workforce. It's a pleasure to introduce Lauren. Take it away.
Hello, I'm Lauren Seno. I'm a research director with NORC at the University of Chicago, and today I'm so excited to share with you all insights from a recent survey we conducted that examines the impact of staffing shortages and the emergence of new technologies on the health information workforce. For those of you not familiar with NORC, we conduct objective, nonpartisan research and deliver insights that decision makers trust across a range of topics. My area of specialization is healthcare, specifically working with organizations that are interested in influencing policy and regulatory actions to create a more accessible and affordable healthcare delivery system. In my area of work, we often do that by elevating the voices of those most impacted by policy changes. In this case, that is the health information workforce, and putting together a compelling story of why things need to be different. For this work, we partnered with the American Health Information Management Association, or AHIMA, to conduct a comprehensive survey of their membership over the summer of 2023. AHIMA's membership consists of thousands of health information workers across the country. These are the people behind the scenes in every healthcare setting imaginable, making sure that every health record is complete and secure. They are the unseen backbone of care in this country, so we wanted to tap into their perspectives and experiences firsthand. We had over 5,000 respondents, and half of that, 2,500, passed the primary screening criteria to complete the survey. That screening criteria was to include only individuals who supervise or have direct decision-making authority on hiring for these positions. Our intent with using this criteria was to really focus on those who see firsthand how hiring is going, those in the room making decisions about benefits for their HI workforce, and those at the leadership level who are devising strategies related to the adoption of new technologies. The survey was designed to achieve three main objectives. Number one, understand the specific workforce challenges that impact the HI profession. There's been a lot of study and research about workforce challenges within healthcare in general, but this was the first, to our knowledge, that specifically honed in on healthcare information professionals. Number two was to assess the role that emerging and evolving technologies, this ended up being something of a catch-all term for AI and machine learning, and how those impact the HI workforce. And then the intent was to take the insights from those two first areas of emphasis and develop and put forward concrete policy recommendations to support HI workforce development. Since this presentation is on the shorter end, I'll only be able to go into select findings, but I strongly encourage you to check out the full report. The link is included here. You can also just type a HEMA workforce survey into Google and it will be the top result. I also want to shout out our partners at AHIMA. They have done an incredible job to engage the HI workforce around these issues and have a ton of resources, trainings, webinars, papers, you name it, to support HI professionals. If this is a topic of interest for you, I highly encourage you to check out their website at ahima.org. Now, onto a few of the top line results. So 66% of respondents indicated that their organization has experienced HI understaffing in the last 2 years. That is, to say over half are saying that they are operating below full capacity because of understaffing issues. The second number, the one in the middle, 76% say that burnout and dissatisfaction with their roles is a direct consequence of that understaffing issue. We'll also dig into a few of the other reasons in a minute, as well as what leaders in the field are doing to combat that issue. Third, and all the way to the right on the slide, 75% think that upskilling of the current workforce is needed for the HI profession to succeed. This number is in direct relationship to another one that I'll share on how bullish they are about the adoption of these new technologies. Before we dig in a bit deeper into the numbers, I want to provide a quick orientation of these slides and how we generally present survey results. For every chart, there will be two common elements. One, the question as it was asked in the survey, and two, the N, the total number of respondents for each question. Both are located in gray below the charts. The N for each question differs for two reasons. First, the survey questions were not all mandatory. Some were optional, everyone other than the screener questions. So each respondent may not have answered every question. And two, some of the questions are contingent on an answer to a previous response. For example, the only people who would get questions following up and saying, what have you done about understaffing, are the ones who said affirmatively, yes, we do experience understaffing. The vertical bar chart on the right half of the slide represents responses submitted by respondents that indicated that their organization has experienced understaffing. Respondents were asked to select all consequences that apply. Percentages are reflective of the number of responses who selected a particular challenge divided by the total number of respondents who answered the question. So that's why they don't all add up to 100 if you're thinking from top to bottom. Okay, with that all out of the way, we'll get into the more juicy details. As before, 66% of respondents experience understaffing of HI positions. When we dig in and asked what that has done to their organization, the picture was a little bit grim. 76% said employee burnout or staff dissatisfaction occurred. 46% said that it led to higher staff turnover, which in a chronically understaffed environment is especially problematic. And this one is the one that will get executives to perk up and pay a little bit more attention here. 48% also said that it led to decreased reimbursement and slower claims processing. This really helps underscore the value of these roles within a health system and the need to focus on better supporting this segment of the workforce. When we look at the next set of results, what are organizations doing to address this issue? Number one answer is increasing pay, followed closely by increasing remote work opportunities and increasing job training opportunities. Interestingly, right in the middle there in the lighter blue, only a quarter said that they weren't doing anything to address the issue. I can't decide if this feels high or low, but my guess is that it's less about wanting to do something and more about having the budget or the support to do so. For the emerging technologies piece, and this is likely what's driving the next number that I'll talk about, slightly over half of respondents believe that their use of AI or machine learning is going to increase in the next 2 years. This likely isn't a surprise. I feel like AI is everywhere right now, but it does speak to the expectation that these technologies are here to stay and are going to have an impact on the HI workforce. Today, AI and machine learning are mainly used for computer-assisted coding, something that should ostensibly assist with coding accuracy and completion times. However, it takes time to adapt to working with these new technologies, and even more so time to ensure that they are accurate. All of that is leading to the consensus that upskilling of the current workforce is needed. This may be upskilling to use the technologies, it may be upskilling to do other functions that may be replaced by the technology. It may also be to build capacity to oversee the technologies and develop new and innovative ways to deploy them to better support HI workflows. So with all of those insights, as well as those within the paper that I wasn't able to cover here, it led to the development of 3 policy recommendations. The first is that federally funded rapid upskilling programs for HI professionals are needed to equip the current workforce with the technical skills and capacity to oversee adoption, implementation, and the use of AI and ML tools. The second is that HRSA or other accountable government agencies should also fund research on the impact of specific AI and ML tools on administrative compliance, staffing needs, and patient-related outcomes such as readmissions, safety, and care experience. And then the third is that NIST should consider convening AI experts and HI leaders in a working group to develop such standards for health systems and hospitals. Okay, so that was a lot of information. In closing, I just want to say 2 things. 1, the HI workforce is a critical component of our healthcare delivery system. They may not be considered in the same frontline capacity as many clinicians, but just about every service that is delivered to a patient is interpreted or touched in some way by an HI professional. Investment in their success is paramount. And then 2, AI research and policy is not just a buzzword to us at NORC. This is an area ripe for research, data, and real-world evidence to begin to uncover how we create policy and industry standards that both allow for innovation, but also protect people from harm. If this is something you are interested in, please get in touch. We love to connect with other organizations that are interested in work in this space, and we have a number of data assets, both qualitative and quantitative, to bring forward reliable and credible research to guide your decision-making in this space. With that, thank you.
Nice job, Lauren. Thank you. That was a lot of information. I have a couple of questions to start off this discussion. One of them is just related to your process, and another one is related to the content. I'll go with the content. AI is moving into just about every aspect of healthcare. How do you see the policy environment responding to this?
Mm-hmm. Yeah, thanks, Betty. And thanks everyone for listening. It's definitely a specific kind of torture watching a pre-recorded video of yourself play out, but thank you all. So as it relates to the policy environment, I think, I've heard it described as a tapestry before. So there are going to be things that are happening at the national level. There are things going to be happening at the state level. And then even at the state level, there's going to be different levels of policy making and regulatory activity that are going to impact different areas of healthcare. I think as it relates to the hospitals and specifically folks who are working in the HIT environment, it's the Office of the National Coordinator, or previously the Office of the National Coordinator, now it's the Assistant Secretary for Technology Technology and Planning. I think a lot of the policy that is going to be applicable in this space and to health IT workers is going to be, or health information workers is going to be from the federal level. I think that that's going to be a big area of focus. Regardless of change in administration, I think that this is going to be an area of increased regulatory focus in the next 5 to 10 years.
Okay, thank you. And then what about this is your process. In developing the survey and you had to develop a bunch of questions to ask, who did you speak to help you formulate, or what research did you do to formulate the questions to ask?
Yeah, For sure. So we worked with the AHIMA team. We worked really in lockstep with them to create the goals for the types of questions we wanted to ask. NORC, as a research organization and one that has been doing surveys for over 80 years now, we brought some of the methodology and how we ask questions and how we can get the right answers based on the questions that we want to ask. But we really consulted very closely with AHIMA, who represents all of these health information workers, as well as groups external to AHIMA, but that work in this field. So we spoke with folks from the Gravity Project. We spoke with people who are in the field today who would be the types of people who would be responding, just to make sure that we are capturing the full breadth of questions that needed to be asked. Because ultimately the goal of this is kind of an elevated version of storytelling. We want to make sure that we are capturing the voices of those folks who are directly impacted. And in order to do that, we needed to construct the survey in order to solicit those opinions very directly.
Okay. And so were there a couple of things like that you felt you went into it knowing that were validated, and then there might have been something that you were surprised by in the data? I don't know if you could speak to one or two of those before we move to the next presentation.
Yeah. So I think a lot of it was we went into the survey understanding that there are challenges in this space. This is what AHIMA had been hearing, is that hiring is really difficult, especially with COVID. COVID really scrambled a lot of budgets at hospitals. It scrambled where people were working from. And it really changed the dynamics of the workforce in healthcare at every level, and including with health information. And so I think a lot of that was confirmatory when doing the survey. It was, okay, there are problems. I think I was personally surprised at how motivated these sites were in the hospitals that we surveyed, how motivated they were to implement changes to address that. I think that was one of the numbers that I referenced, is like people, they are working on increasing pay. They are working on integrating other technology and solutions in order to offload some activities so that people can work more towards top of their license. So I think in a lot of ways there were some surprises, and I think that part of that surprise was just seeing how innovative folks were being in terms of shoring up this corner of the workforce.
Okay, well, thank you. And that certainly was a proud moment that was worth sharing. So thank you, Lauren, and we'll chat with you a little bit more at the end. The next up for us is another proud moment, and I have the pleasure to introduce Katie McGraves-Lloyd, who is Principal Health Data Analyst at Onpoint, and Pamela Mink, who is a Director of Health Services Research in the Health Economics Program at the Minnesota Department of Health. And their proud moment is pretty big. They completed a pilot study related to the collection of non-claims payment data. So listen up, because I think many of us can leverage the knowledge that they got from their pilot study. Here we go.
Hello, my name is Pam Mink, and I'm the Director of Health Services Research at the Minnesota Department of Health. And I'm here today with Katie McGraves-Lloyd to talk about a recent pilot study we did on the transparency of healthcare payments, looking at non-claims-based payments data collection in the Minnesota All-Payer Claims Database. So today we'll talk about the lessons learned from a pilot study to inform the beginning and ongoing data collection in the Minnesota All-Payer Claims Database of non-claims-based payments. I'll talk a little bit about the background and context for the pilot study, the aims of the study, and then I'll pass it over to Katie from Onpoint to talk about the lessons learned. So this whole project has been a collaboration between the Minnesota Department of Health and Onpoint Health Data. So as some background, understanding healthcare spending, including drivers of costs and distribution of payments, is critical to designing and monitoring effective policies to contain costs while improving the quality of care and population health. As most of you know, the foundation of all-payer claims database is claims data, but spending estimates derived solely on claims data will miss payments such as bonuses or rewards that the health plans make to provider organizations that occur outside of that claims transaction process. So we use the term non-claims-based payments to describe and categorize payments to healthcare providers that are designed to pay for the value of the healthcare services rather than the volume of healthcare services. And so this includes value-based payment models and alternative payment models are just some other terms used to describe this. The legislation was passed in Minnesota to enhance transparency and accountability in healthcare payments by requiring health plan companies and TPAs to report the non-claims-based payments that they make to healthcare providers. So on the left, you can see that the formal data collection in Minnesota will begin sometime in or after 2025, and that the Minnesota Department of Health was directed to consult with health plans and provider organizations as we develop the reporting forms and other requirements. On the right, you can see that MDH was also directed to submit a report prior to when the formal data collection begins that focuses on the volume and distribution of spending across payment models with a particular focus on value-based models in primary care. So in preparing the report, we were directed to describe the form and manner for the data collection, ensure that the data collected permits calculation of total claims-based and non-claims-based spending overall and for primary care, and to conduct interviews with health plans and TPAs to understand the types and purposes of non-claims-based payments and models. So this is what we're referring to this report as our pilot study. And the ultimate aim of this effort then is to be able to better describe and understand value-based payment models, to allow for more complete analysis of healthcare spending, and to inform the Minnesota legislature on payment models to promote health, to reduce disparities, and to support primary care services. MDH contracted with Onpoint to conduct the pilot study, and the main tasks of this engagement for this study were to conduct an environmental scan to assess the landscape of non-claims-based payment data collection in other states, to conduct interviews with Minnesota public and private health plans to ask about non-claims-based payment arrangements that they have with providers, to create and pilot test a data collection tool and a process for data submission, and then to summarize the key findings and lessons learned. So the pilot study was completed in the early part of this year. The results will be used to inform future non-claims-based payment data collection by the Minnesota All-Payer Claims Database. And I will hand it over to Katie now to talk about the lessons learned from this pilot study.
Great, thanks, Pam. Hi, everyone. I'm Katie McGraves-Lloyd. I'm a Principal Health Data Analyst at Onpoint. And as Pam said, I'm going to talk about some of the lessons learned. So we've chosen 5 lessons to talk about. This is the high-level view. I'll go into more detail on the subsequent slides. But the first crucial lesson is engaging and consulting data submitters. Secondly, defining the data to be collected. So for example, the populations, what template you're going to use, what fields you're going to collect. Third, to provide clear directions and support. So for example, webinars to help submitters understand the DSG, or office hours, other companion guides. Fourth, to review data submissions to ensure quality and provide adequate timing for that validation process. And then fifth, trying to encourage compliance by considering incentives or penalties. So let's dig into the first one a little bit, consulting and engaging with data submitters. So something that was really valuable that we did in the Minnesota project was before we started data collection, we conducted submitter interviews. So we created an interview guide, and this is really about socializing the template, understanding questions that submitters had, as well as learning about specific non-claims programs the submitter had. For example, this is really valuable with the Medicaid program. There is a specific program that the submitter had some questions around how to categorize that based on our framework. And so we worked together to understand that program and how to categorize it. Also, another example, as Pam mentioned, Minnesota was really interested in identifying primary care spending. So we asked the submitters if they were able to identify how much of a payment would go to primary care. And the answer we heard most of the time was that that was really difficult because the payment was made to a multi-specialty practice. But regardless of those details, these conversations highlighted key aspects and helped us inform the collection. And then following collection, just solicit feedback on their prior collection efforts. So we have lessons learned, but also hearing those from the submitters is valuable. Lesson number 2, define the data to be collected. So here I have a couple questions related to data collection. For example, what reporting periods will be collected, and how does that reporting period relate to a submitter's reconciliation timeline? For example, if you're interested in collecting data through December 2023, but you start that collection in December 2024, that's 12 months available for the reconciliation period. But if a submitter has an 18-month reconciliation period, you might get $0 or have to talk to them about providing an estimate of their spending. what submitters will be required to report. So are you interested in all submitters who are required to report to the APCD, or perhaps the 4 submitters that make up 95% of your population? How will the population be defined? So thinking whether that's residents where someone lives or situs where their insurance contract is. What types of non-claims-based payment data will be collected? So are you interested in annual payments, pharmacy rebates, capitation? For this pilot study, we collected annual payments, but in future iterations, there's interest in pharmacy rebates as well as other sources. And what template will be used to collect the data? We use the NATO template, understanding that there's also a Milbank work group going on at this time. So thinking about how you'd like to collect the data. Lesson number 3, provide clear directions and support. So how will submitters be supported in understanding and validating the format? Something that we found really valuable here was creating a list of data quality checks to evaluate the submission. And so perhaps that could be sent to the submitters prior to submission. We also created the DSG. We had a supplemental instruction manual. We had a webinar to introduce the submitters to the DSG. And something that we're thinking about in the future is offering office hours to submitters as well. Lesson number 4, review submissions to ensure quality. So how will submissions be validated? I mentioned this on the prior slide, but something that was really valuable, we created a data quality checklist to validate each submission. States may consider sharing the checks with submitters prior to data collection. States may consider engaging with submitters who have historically had data quality challenges. They may need a little extra help with the submission. And I think it's important to estimate at least 6 to 8 weeks for validation. So if you just think of one question, maybe it takes a submitter a week to respond, and then a week to fix the issue, and then you need to validate that, and you're already 3 weeks into your validation timeline. So timing is important there. And then the last lesson is to encourage data submitter compliance. This could be done a number of ways, incentivizing by tying data reporting to the contracting process through rate setting or via licensing authority. States could also explore penalizing for poor quality or delayed reporting. The last item I'm going to talk about are sort of putting these steps together. How can states implement non-claims data collection? So here are some thoughts on those implementation steps. So step 1, really valuable, the submitter interviews, socializing the template with the stakeholders, getting their feedback, understanding the landscape of non-claims payments in the state. Number 2, incorporating findings into documentation. So this is preparing a thoughtful and thorough data submission guide, frequently asked questions, and validations document. Number 3, providing submitters with helpful notice. So letting them know about this data collection and giving them enough time to be successful. Step 4, offer consistent support for submitters. So this is around the webinars, the office hours, maybe engaging with submitters who need more support. And number 5, receiving and validating the submitters files. So making sure to allow ample time for validation and iteration, as well as creating those key documents like a data. Thank you so much for letting us share about the Minnesota pilot project to collect non-claims data. We welcome any questions at this time.
Well, thank you both, Pam and Katie. That was wonderful. I was sitting here watching, especially the last slide, and realizing that anyone watching this presentation really should be capturing that as a framework. It was a pilot, but we really set up a framework for the data collection, and it's not a simple thing. And I know from my experience that the steps that you had in there take time, and all of those steps are really, before you even really use the data. It's like just, I wrote down soliciting feedback, socializing the data collection, defining the data within the submission guide. Those are all complex, time-consuming things, but I like the way that you laid out the framework. Certainly it's a proud moment. I do want to ask a couple questions. One general question, if you could, you hinted at a little, what, either Pam or Katie, what were some of the challenges that you ran into as you were doing the pilot?
Thank you. One of the challenges was really in sort of thinking about getting back to some of the questions the Minnesota legislature had that prompted this study. So one of the things that motivated this was to try to get a better handle on what is actual spending in primary care and what's investment in primary care. And one thing that we learned through the course of this is most of the plans, when they make the payments back to the providers, they don't know exactly how those funds are allocated. And so we had a way, thanks to Onpoint, of kind of estimating where it wasn't clear, but there's still some kind of fuzziness and understanding kind of where is that money going and for the non-claims based payments.
Yeah, I feel your pain, and it's almost like, I like your terminology, fuzziness, or I would say the secret sauce. And I do think that that is a big challenge, trying to really isolate the non-claims piece. So maybe talk a little bit more about that, Katie, and that if you made some assumptions, or share with the group how you dealt with that.
Offer them to MDH to make a decision. So there previously was a Milbank work group on collecting non-claims data related to primary care payments. And that group had suggested sort of like default percentages for specific programs. So, you know, like an EHR incentive, none of that would go to primary care. But another arrangement, maybe 10% would go to primary care, or 20% of that payment would go to primary care. So we sort of offered the default percentages from the Milbank paper as one option. The second one was using the data we had. So some plans were able to identify the percent of payments related to primary care, while others weren't, for the reasons that Pam gave. And so we used the data that we did have, the non-missing data, to sort of create like average percentages by each of those payment categories, those non-claims payment categories. And I think that's what MDH ended up using in the end.
So how did those, and not to get too into the nitty gritty, how did those percentages impact like the submission guide in terms of the data that was submitted?
So the percentages, that was kind of like what we did in the back end on the reporting. It didn't impact the data submission guide. So it wasn't like a threshold in the data submission guide. We just kind of like took what we could get for that information, because we knew from those submitter interviews that not every submitter could parse out the primary care spending. So we knew to expect some $0 there. So they were kind of separate, the collection and the reporting.
Okay, so you applied the percentages after you got the data.
Right, yeah, and sort of like the analysis of the data. Yeah, Pam, go ahead.
No, I was going to say, because our report to the legislature, one of the requirements is that we break it out by primary care and non-primary care. So Katie's right, it's not, it has less impact on sort of the data collection, but in what we were asked to do with the data, we had to make some of those decisions and considerations in how to best estimate that.
Okay. I'll ask you the same question that I asked Lauren. Were there any surprises as you went through the pilot study that you want to share with us?
I don't know if I'd call it them. For me, I don't know if there's surprises. There were some, there were definitely some things we had to stop and think about, but, and some of it, I think, Betty, is what you were saying, is like, it's hard to really draw a line between here's all the claims-based payments, here are all the non-claims-based payments, because there's some overlap, that a lot of non-claims is built on the claims chassis. But I feel like I was enough prepared for that. It wasn't a total surprise. But Katie, anything that surprised you? Katie might be frozen.
I think she's frozen.
Yeah. I think one of the things it did was it really affirmed for us how important it is to have good communication with the data submitters, in this case, the payers, when embarking on something like this, so that we can really understand kind of how they have this information and how best to, create a data submission guide that will be, friendly to them and also get us the data we want.
Yes, no, I got that from your presentation, that the importance of the outreach to the stakeholders. Okay, well, I think we lost Katie. So I think we'll wait to see if the audience has any questions, but thank you so much, Pam and Katie. She'll be back. And I think we'll move on to the next proud moment or challenge. And it turns out it's a difficult challenge. And we will have Andrea Clark of CareQuest Institute for Oral Health. If you've never heard of them, they are a champion of oral health transformation. And Andrea is a nationally recognized expert in the analysis and application of insights from all payer claims database. And she's been kind enough to share with us some challenges related to the collection and the use of dental data. So here in Massachusetts, we have been collecting dental data, but honestly, we haven't done a lot with it beyond collect and prepare it. So I'm interested to hear what Andrea has to say about the challenges. So pleasure to introduce her, and I think we can move on to her presentation. Thank you.
Good day all, and welcome to the National Association of Health Data Organizations 39th Annual Conference. I'm Andrea Clark from the CareQuest Institute for Oral Health. We are pleased to be a NADO strategic partner and conference gigabyte sponsor. Today, I'm here to talk about oral health data, specifically dental claims and APCDs. So hey, you've got dental data. Now what? Thanks for the opportunity to share one of my all-time favorite gifts with you. I realize the creator of gifts pronounces it GIF, but I have my reasons, which I'm happy to discuss in the Q&A. But for now, let's move on. 17 states, including most of the OG APCD states, if you will, collect dental claims. I compiled this list using nado.org, apcdcouncil.org, and some additional Googling of my own to fill in gaps about individual states. Do please let me know through the chat or in Q&A if I've missed anything or if you see inaccuracies on this slide, that any mistakes are entirely my own. So, many of us in our state health data assets community have these valuable data, yet not much has been done with them. There are some real challenges to using these data, which we'll discuss shortly. Then I'll make the case that there are valuable opportunities to be unlocked with dental claims and share some initial thoughts about solving the challenges. So for any folks who might not be familiar, that's a picture of grain silos up in the upper right-hand corner, representing the siloing of the dental profession from the medical profession. And this reverberates throughout our healthcare system, from everywhere through your doctor's electronic health record, clinical records, not communicating with your dentist's electronic dental record, to the fact that in the APCDs, your dental claims are likely sitting in a separate file, or many of them are. We'll talk a little bit more about that a little bit later. So the critical patient data about someone's oral health is siloed and censored, not seen by the medical profession, and vice versa, which is a real problem. Completeness. Who is sending you dental claims? Who isn't? States collecting the data may not be collecting from standalone dental insurers, which is dominant in the commercial sector. With Medicaid and CHIP, all kids and adults in some states have dental coverage. Now that data, if you're getting the Medicaid data in your state, it's probably sitting in your medical file because that comprehensive coverage covers both medical and dental. So as always, the broader point is that it's hugely important to be sure you understand what you have and where it is in order to successfully leverage the data. Next, there are no diagnosis codes in the dental claims. There is a diagnosis code field on the standard dental claim layout, but don't get your hopes up. You'll find it basically empty. It's not required for dental reimbursement. So we can observe on the dental side generally in claims data what procedures were provided, what procedures were paid for, but we can't see what conditions exist, what oral health conditions exist for that patient population. Member ID mastering. Generally, as the data stand, unless you have, like, children with Medicaid, for example, that comprehensive coverage that includes both medical and dental, you can't track folks across between their medical and dental coverage, because that hard work of figuring out a master ID across the, the medical, the pharmacy, and the dental, hasn't been done. Also, you have the issue I mentioned before about with comprehensive coverage. The dental may well be sitting in your medical files. So if you are digging into dental procedures for analysis, I do strongly recommend checking both the medical and the dental files for that utilization. Versioning and Q&A. In my discussions to date with friends at state health data organizations indicate that one big barrier is finding the resources to dig through the dental data, do that critical quality assurance work before making it widely available or using it extensively for analysis. Also very scarce, are the time among the human resources for someone on the team to build the expertise around oral health data to do that work for the dental data. Although there are real challenges, there are also opportunities foregone when we don't leverage available dental claims data. Oral and systemic health are deeply and importantly linked, with oral health or oral disease, specifically gum disease, being a risk factor for numerous chronic conditions, including cardiac conditions, diabetes, preterm birth, preeclampsia in pregnant people. And improved oral health is linked to improved outcomes for many of these conditions. And some studies have even suggested that treatment of these oral health conditions can reduce total cost of healthcare for individuals. You can check out the paper at the QR code on this slide, which was published in a peer-reviewed journal by some of my colleagues last year. And it showed that folks who had periodontal treatment and diabetes had lower costs of care on average, quite significantly so, than folks with diabetes who had not had periodontal treatment. This slide includes another Institute publication, an infographic highlighting several of the oral systemic connections that I touched briefly on in the last slide and going into a little bit more detail. I'd encourage you to explore it in detail when you have a chance. It's actually really pretty fascinating. You can access it in this slide deck when it's published, or you could scan the QR code on the slide. And then in another recent paper, my colleagues and I shared findings on alternative payment models in the Medicaid space. And once again, we found that information on the oral health side was absent or lagging. Although this study was not conducted on claim data, better availability of dental claims could have anchored our research, giving us an X to mark the spot to sort of start digging, in a specific state or around a specific program. Also, increasing prevalence of APMs highlights the need to get our hands around the claim data. I'd argue that understanding the current fee-for-service claim landscape is a necessary condition for designing smart APMs, appropriate tracking mechanisms, and around, designing intelligent medical dental integrated payment designs or treatment designs. And one final QR code for everyone. Let's use the power of our community to come together to solve the challenges and seize the opportunities of dental data. Tomorrow, I'll be hosting a dental data networking session room at 2:20 p.m. Eastern. I hope to see many of you there. We're also pleased to announce the launch of NADO's Dental Data Users Group. Please scan the QR code or go to the link in the chat to fill out a quick form to share your interest. Charles and I will be in touch about participating. I thank you all for your attention. I look forward to your questions, and I hope many future conversations. Betty?
Andrea, good job. Wow. I'm impressed, and I learned something about. I like how that slide with the challenges, and then talking about the integration of the data. Here's a question for you. Given the challenges, what do you recommend as a starting point for creating value from the dental data that's been collected? Because as you showed, a lot of states have the data, but we would love to get more value from this data that we're collecting. So how do we start?
That's a great question. So thank you for that, Betty. I think one thing that springs to mind is, and actually I really came to this insight while preparing this presentation. One starting point I think could be really valuable is to look at your child Medicaid population. If you are getting a rich feed of Medicaid data from your state, because you're going to have, again, that comprehensive coverage. And so you'll be able to track, you should, in theory, be able to track your kids across the medical and the dental. Now, I make that sound so simple, but if you have, if you have different MCO covering someone's dental and someone's medical in a particular state, that that may not hold, but there's at least a chance there that you might be able to look at that comprehensive data and sort of leapfrog off what you know about the medical data within your state's Medicaid program to have some stakes in the ground and looking at the dental. With the where that's not really possible. Again, I guess the other place I would go is for example, I believe there in Massachusetts, I believe Blue Cross Blue Shield does do some what's the word I'm looking for? Comprehensive plans that include both the medical and the dental. And I guess I keep returning to that because I think with where you've got that integrated coverage, you're probably going to have, again, and I'm sorry to be a broken record here, but you're going to have those stakes in the ground around, you're going to be able to find your eligibility. You've already,
no, it's good to repeat. I appreciate it.
yeah. You're going to have that eligibility, all lined up with that data. You're going to know, know who people are. You're going to know what's going on with them, and you can start to get a feel for, for what could be some useful insights out of dental data. In the data set that my colleagues used for that peer-reviewed paper, the work had already been done by the vendor of the data, the data asset, to line up folks both in Medicaid and commercial populations across their medical and dental records, so that they were able to see that, they were able to look and see that folks with diabetes who had received periodontal treatment in the succeeding year had lower total cost of care than those who hadn't, and got that really strong result. Now that might not be what someone's looking to do, but you could also go, just maybe you want to check and see what % of your Medicaid population are getting regular prophylaxis, regular cleanings, or how much of your commercial population is getting those things. Now, with the huge caveat on that commercial side that it's going to be really critical to understand whether your state is receiving data from standalone dental plans before you kind of dive in and make any conclusions.
That's helpful, and it's also validating for me here in Massachusetts. One of the things that you mentioned is, look at the Mass Health or the Medicaid first, which validates us, because that's the approach that we took in terms of preparing and QAing the data. We decided to focus in on the Medicaid, which is really the largest submitter of all the dental data. So it was a bigger win. And I'm glad to hear that you recommend that. So that's great. I have a question. What about the value of the data? Because you mentioned silos. Do you know anything about the value of the dental data as a standalone without the integration? I mean, that we do have MDM here, and that's another project, and we'll probably pursue that. But I'm just wondering about standalone. What's the value of the dental data?
I think there's a lot of potential data to unlock there. One of the aspects that we focus on at the Institute is we have been trying to lead in the space of encouraging folks in the dental profession to collect richer demographic data. Because one of from the dental data as it stands, you can start to get pictures, if you will, of what healthcare, dental oral healthcare needs might be in a particular community. So we've been doing a lot of work around trying to improve real and SOGI, race, ethnicity, and language, sexual orientation, and gender identity data in dental data health systems. You'll probably, if you go into your commercial data on the oral health side, you'll probably find that demographic data collection is lagging somewhat, even where it is in the medical. And one of the things that, as a nonprofit focusing on health equity and health access to healthcare, that we believe is that if we can get that information in the data, and then we can start to really assess where there are, where are the community needs that, and how do we address them? And
So
I think that's one of the real keys.
I love that answer, because I think that is another thing. What I'm hearing is that if, more rich demographic data within the silo would make it even more valuable than it is. And I think that's what we're pursuing here at CHIA. So that's another great validation. There is a question from the audience from Sylvia Hobbs. I'm going to read it. In states such as Massachusetts, where a master patient index is maintained within the all-payer claims, what methodological approach would you recommend to assess gaps in coverage? Specifically, how might one use this index to compare the incidence of emergency department utilization for dental-related issues within the medical claims data against, well, this is the big question. Hold on, Andrea, because I think it's a lot for you to just hear, never mind me read. Within the medical claims data against the absence of corresponding claims within the dental.
Well, thanks for the question, Sylvia. I think that's that would be a fascinating topic to dig into. I think there's a lot of potential there if you have. So, one of your potential pitfalls would be making sure you understand what you have eligibility for. Like, are you certain that this person was either eligible or not eligible for dental, at least as far as you can know within, given who submits to you and who doesn't. There would be the opportunity to say, okay, we see this ED visit for this person who has, and we believe, based on MDM, master, member ID mastering, that this person's over here in the dental, in the dental data. You could check that time series that could show you, gaps in coverage, gaps in care, or point you to that. It could also simply be that you don't get, maybe they have a standalone dental plan that you're not getting reports from. But the kind of to back up a little bit with emergency department data is actually really important to understanding what's going on with people's oral health. And I realize that's actually missing from my presentation, is you can't really get, especially if you're looking at an under-resourced population, you can't really understand their oral health issues without including that ED data, because you do see really high levels in some communities and in people with particularly with Medicaid coverage or uninsured, who are visiting the ED with dental issues. And one of the big problems and concerns with that is that EDs generally do not provide dental care. They give people antibiotics and pain medications for if they have an abscess or whatever the problem might be, and try to help connect them with a safety net dental provider, but really more or less send them on their way. So I think there is a lot of potential there for states like Massachusetts, who have really rich data resources on both the medical and dental side, to start analyzing that, getting some answers, learning where else to look. But it's definitely something that I think would require a significant amount of resources. It's frankly, something I'd love to partner with somebody on. It would be great, to dig around in the data and start figuring out what we can know and what we might not be able to know and what we might need to figure out some of the stuff we don't know, and could be a very powerful source of information. Hope folks could really get that going.
Thank you, Sylvia, for that question, and thank you, Andrea, for the answer and your enthusiastic answer, Andrea, and that you would love to dig into the data and find this. So I appreciate that. I also think it's great that you're offering to start up this user group for NATO. I just want to give a shout out to that, and I think I heard that it's something at 2:20 tomorrow. That if folks are interested in that, they should put that down in their calendar and try to be there, right?
Right. It's one of the networking sessions for tomorrow for the conference. And if you show up to the dental session tomorrow, that does not mean that you have committed to being in the work group. It's just a space for us, the teeth people, as we sometimes call ourselves, as our little dental subculture, to get together and talk about where to start, really.
Speaking of teeth, someone put in the comments, Donald Poe, thank you. Tooth code can be a challenge. I think that I can agree with that here based on our experience in Massachusetts. Yeah, it can be a toothache, not to play on that, but and then just looking at the comments here, if there's anything else. Sarah Crawford, thank you, Sarah, said that ACHI in Arkansas produced a report using dental medical claims data in 2022, and she provided a link. Wow. And she's following up Sylvia with check out pages 35 to 41 in the report on dental care medical claims settings, including ED. Cool. There's someone that's done some work. I have a feeling that there are people out there like Sarah and Sylvia that really, have some valuable insight and experience on the dental. So I really hope that they attend the networking session tomorrow at 2:20. And as Andrea said, it's not a commitment to any group. It's really just an exploratory of who wants to. I think we could really benefit. I'm going to try to be there.
Sounds great.
Thank you. Is there anything else that you're thinking, Andrea, that you want to share with us about your presentation? You're the one that presented the challenges. The other two.
I think I would say I'm really glad, Sylvia, that you asked the question about the ED stuff, because that was kind of a hole in my presentation. I honestly didn't. When you asked the question, I was like, wow, I should have spoken a little bit about that. So I think that's a really important thing to keep in mind. And I appreciate everybody's fantastic engagement on this topic.
Yes, as I'd like to echo what from the keynote this morning that Dr. Gloria Singe, I can't say her last name, but she said, without her team, nothing happens. So with the team, we can make things happen. So I don't know, Charles, if you want to bring back the group, we might have some time for any other questions to anyone in the whole session. I'm very proud of all of you for your presentations, sharing your key points. Looking to see if I have anything. One thing I might ask is on for Katie and Pam. I think that one of the challenges around the primary care was really trying to isolate the non-claims payment. And I think I heard you mentioned that you were using the NATO template. If there's anything that you want to say about the experience of using that template to share with the group here.
We socialized it in the submitter interview, and they were able to populate it well. I think we had a couple conversations with plans about like specific one-off programs, and they wanted to talk to us about how to fit it in, but those usually just went into another bucket. But I'd say it was generally well received and a useful tool.
That's great feedback. And so I hope others heard that and can use that. Thank you for sharing that. I don't see any other questions. Is there anything that any one of the presenters kind of had a thought that they want to either ask a question or share anything? Please feel free. Otherwise, we might be able to finish early.
We are actually right now at the end of time, Betty. So, so I see a lot of complimentary comments here in the chat. So let me say thank you to everyone for joining, and thank you to all the presenters and Betty for moderating. I will just say that in less than 10 minutes now, we will start the last plenary session of the day, filling population health gap, which feels gaps through data linkage. Apparently we truncated here. So I'll see all of you over there. Thank you again. Have a nice rest of your day.
Bye-bye. Thank you.
Thank you.